So, ladies and gentlemen, it is your privilege now to hear directly from Ajay on patient selection and procedural tips and tricks for the success of renal denervation therapy. Ajay?
Thank you so much, not only for that kind introduction, but also Srinivas for that before. That was a surprise, and thanks so much for it. It means a lot. So I'm going to talk briefly about patient selection, tips and tricks. I'll touch a little bit on the data because I think it's important to frame when you're going to offer this to patients what types of benefits they might be able to expect. I'll also talk a little bit about pathophysiology in this talk. As mentioned, I've worked with both Medtronic and Recor on their study designs, et cetera, but don't take any specific consulting money from them. It's really just for the research. These are data from the United States showing that despite the fact that we have many antihypertensives available, the rates of control for patients with hypertension are quite poor. The rates of control languish around 60% or so, and even among those that are on medications, the rates of control have not really gotten better. In fact, they're plateauing around 60 to 70%. So much more work that we need to do, and in fact, in this past year, the World Health Organization has categorized hypertension as an epidemic of sorts. This is a real public health issue, and certainly we'll see all the tough cases that we introduce ourselves in the cath lab with coronary disease, strokes, and beyond, and a lot of this can be attributed to hypertension at baseline. I think one of the reasons for this fundamentally is that there are differences in perception between patients and physicians. And on the left are physicians who basically prescribe medications, and they say, just take these medicines, it's going to be fine, you're going to control your blood pressure. But many patients, and we were having a conversation at dinner last night, we ourselves may be patients, we have this hesitation to take medications because we don't want to take pills that maybe are for a condition that we don't really feel. And so there's this distance between what we do as physicians and what we might do as our own patients, and certainly the patients that are out there. I'll give you an example of this with a nice case that is from Naomi Fisher in Boston. And I'm a sports fan, and so this is an important case that has a sports analogy. And in the United States, the Yankees and Red Sox rivalry can probably be likened to the India-Pakistan cricket matches. And so clearly a lot of sympathetic activation that can happen when you're rooting for these teams. And so this is a patient who presented to clinic, had a blood pressure of 144/92, not that elevated, but definitely elevated. But the reason it was elevated was because he had just been watching the match, and that's why it was elevated. So 2 weeks later, comes back for another blood pressure check. It's 142/90, but the reason is that his team had won the World Series. And so as a result, that's why the blood pressure was elevated. Comes back again the next year, blood pressure is elevated, but it's not because of the baseball this time, it's because he has arthritis pain. And then still doesn't get medications, but the next time comes back, but he took the stairs to the clinic, that's why his blood pressure was elevated. 2 months later, he had stressful week at work, didn't really get parking easily, then he missed an appointment, comes back later, finally agrees to be diagnosed with hypertension and wants to try a low-salt diet. No more salt, 3 weeks later, blood pressure's elevated, okay, I'm gonna start joining the gym, and this goes on with side effects to medications as well. And while it may seem that this is a contrived story, the reality is, for many patients, this is a real existence, except they don't get to see the physician this frequently. And so there's years and years of untreated hypertension that goes on because of this unwillingness or resistance to take medicine for a condition that they don't really feel. They're not having headaches, they're not having cardiac symptoms or anything like that, and even those that do are still often resistant to take medications. Maybe some of you in the audience have hypertension. Just think it to yourself. Are you taking the medicines regularly where there's a resistance to taking the medicines up front? And this is the problem with hypertension as a whole. There are actually some data that show that 50% of medications patients actually stop their blood pressure medications within a year of starting them. And this is sobering, and this does not mean we should denervate all these patients. What this means is we have to be better physicians at convincing our patients why they ought to do lifestyle modification and medications before we even consider them for denervation. And then the most sobering data is actually this extended follow-up in the community of the SPRINT trial. As many of you know, SPRINT was published in the New England Journal of Medicine and showed not only blood pressure reductions, but mortality reductions with more intensive control of blood pressure. But in this paper that came out in JAMA Cardiology last year, once those patients that had been randomized to the intensive arm were sort of disenrolled from the study and went back to regular community-based practice, their blood pressure drifted back to where it was at the start of the study. And as a adjunct to that, the mortality benefit they got went away. So clearly, it's not just upfront telling them that it's important to take your medicines, but you need to sort of emphasize adherence over the long term. So this sets the stage for denervation. We shouldn't be denervating all these patients. We should be educating them better. But in those patients that have sympathetically elevated drive as a pathophysiologic construct for their hypertension, those are the patients that may benefit from renal denervation. So many stages and many types of hypertension have elevated sympathetics as part of the hallmark pathophysiology, and so that's one of the reasons why it's an attractive target. But I would also like to point out that there is somewhat of an age dependency to this, and while the trials of denervation have included patients across the swath of ages, the majority of patients have ages that are mean approximately 50. And if you look at sympathetic activation as patients get more and more elderly and the arteries get more and more stiff, elevated sympathetics tend to be less important as a pathophysiologic construct for why they have elevated blood pressure. It's often arterial stiffness, volume dependence, and something like that. Now, there are certain patient populations that would actually benefit quite a bit, and this is a World Cup slide in the New England Journal of Medicine, which is super interesting. In Bavaria, during the World Cup, you see these spikes in ACS admissions that coincide with the Germany soccer team's games. And so you know that clearly sympathetic overdrive is a hallmark of pathophysiology for many patients, and if we can target these types of patients, then well, maybe this is going to be more effective. We heard a little bit about the data. I want to actually focus on the actual numbers for this, because if we're going to talk to our patients, we can't tell them that they should expect a 30 millimeter of mercury drop in blood pressure, which was the type that Venkata and I saw early on in 10 years ago, where people were assuming that this would cure hypertension. It actually turns out that even in the first case report in the New England Journal of Medicine, I'd like to point out that the baseline blood pressure was 161/107 on 7 medications. But the dramatic improvement in blood pressure on 7 medications was only from 161 to 141. So it wasn't curative. The patient still needed to be on a bunch of medications, and it's really important to level set that when we talk to patients and physicians who may be referring these patients to us. We are not going to cure their blood pressure. This is an adjunct to try to achieve a better level of control than they would have otherwise had on their medical regimen. They may be able to come off of some medications, but it's not like they're going to come off of medicines altogether. Now, it's also important to recognize that with these technologies that there's been iteration of the devices over time. And this is in part due to the recognition that the nerves approximate the arteries as you go more distal in the bed itself. Before we're focusing our energy on the ostium, it turns out that's not where we should be focusing. We need to go a little bit more distal or use a more circumferential type of technology. And it's very important to achieve an adequate ablation, because if we only ablate a few nerves, we're not going to get a blood pressure effect. And a lot of the preclinical data that's come out in the past decade or so has actually pointed to this and suggested that you really need to ablate a certain number of nerves in order to get a lowering of blood pressure. That's where technologies like the spiral catheter have come in. Unlike the single polar catheter that was used in the original HTN-3 trial, the device which you saw in the previous talk, applied more distally with multiple electrodes, is more likely to get a clearer drop in, or a clearer ablation of more nerves, and that's how you'll get a drop in blood pressure. Now, remember, you can't just do the main branches with this catheter. You have to go distally into the sub-branches. It's a longer procedure, but a more effective denervation, and that's how you lower blood pressure. What is the lowering of blood pressure that you'll see? And it's much more modest than you saw with those initial studies that came out perhaps 10 years ago, suggesting there were going to be drops of 30 millimeters of mercury or more. I personally am a little bit skeptical of the data that was presented at the Europe PCR with drops of 20 millimeters or more seen with that catheter. In general, the drops that you see are more commensurate with approximately reductions of about 10 millimeters of mercury or so in office blood pressure as a whole. This is true irrespective of whether you're off medications in the study design or on medications in the spiral HTN on med. And in the pivotal trial that was presented at the AHA, we basically saw similar types of reductions in office blood pressure of approximately 10 millimeters of mercury. Despite the fact that the primary endpoint was negative, you clearly saw reductions in office blood pressure commensurate with this. Now, what about other technologies? Ultrasound technology, this is the technology that I've had the opportunity to work on. This operates a little bit differently. You don't have to go as distally in the vessel because there's a circumferential ablation that takes place. it tends to be a shorter procedure as well, and tries to get deeper in a circumferential fashion rather than having to go distally into the vessel bed. What we showed, and this was published in JAMA Cardiology earlier this year, is very similar reductions in blood pressure, approximately 10 millimeters of mercury from baseline in office blood pressure, obviously statistically significant compared to the sham control. But what's important is that that 10 millimeters of mercury is a mean. It's an average. There's some patients who are going to have greater effects, and there's some patients who are going to have lower effects. But what is pretty clear is that irrespective of where you are in comparison to sham, there are going to be, the majority of patients are going to have at least a 5 millimeter of mercury change, and half of them will have a greater than 10 millimeter of mercury change. So that's important for your patients to understand. Similarly, where you start off with in terms of your blood pressure will impact where you end up. If you start off with higher blood pressures at baseline, in general, you're going to get a greater blood pressure response. But you're also less likely to be controlled if you start off very, very high. On the other hand, if you start off closer to 140, then you may get less of a drop as a whole, but a greater chance of being controlled. Now, what about procedural tips and tricks? Well, number one, I would say that you want to obviously try lifestyle modification and medications up front. If the patients are coming in general, they're going to get a CT scan to rule out things like adrenal adenoma or secondary causes of hypertension. And this is just an example of pre-procedure planning showing that, in this case, there were 2 single renal arteries. 20 to 30% of patients will have accessory renal arteries. If they're big enough, they need to be treated in order to effect a complete denervation type of procedure. In addition, in this case, you can see the parenchyma of the renal artery is kind of close here. So if you're going to use a deep circumferential technology like ReCore, you want to be careful and not go that far distally. If you're going to use the Medtronic device, which tends to go less deep, you're obviously going to go beyond the distal bifurcation. So I do think pre-procedural planning with something like a CT scan is going to be important for laying out how you do the procedure. When you come to do the procedure, both of these procedures are femoral. This is actually from a case that we did not too long ago. This is a very experienced operator. You'll notice he's getting access using ultrasound. These are 7 French catheters. If patients are coming in for a procedure for hypertension, you can't cause a vascular complication. If you'll notice, the access was obtained with ultrasound using micropuncture. Why am I talking about access at a meeting like this? Because it's always important to cover the A's, B's, and C's. And if you look at where this access point is, it's way too high. So therefore, he pulls out the micropuncture, he pulls out the needle, holds pressure, and re-accesses at an appropriate spot. This is a way of limiting vascular complications. The last thing you want to do for somebody who comes in for a procedure like this is to cause a retroperitoneal bleed, and so now repeat access is obtained. This is a femoral angiogram that's taken, showing that actually there may be some haziness at the ostium. You don't want to do a renal denervation procedure where there's an existing stenosis, because theoretically you could make that stenosis worse. So what actually we did in this case, this is careful wiring with an 014 wire. All cases you need careful wiring. You come out of the guide very, very carefully. You don't want to dissect the ostium. And then you find a safe place for the distal wire to go so as to not cause a distal wire perf, because this has to be done with high degree of safety. And so there's careful manipulation. You see the wire going more distally. There's a loop there. That loop can be used to your advantage, but it's going in a strange place. So now with wire manipulation, it's going in a more safe location. And then once that happens, in this case, we actually performed IVUS. Why did we perform IVUS? Was because there was a question of a lesion at the ostium, and we also wanted to measure size. So here's the IVUS that's done. You don't have to do this in every case. The reason I'm showing this case is because there were some challenges, and we wanted to make sure what was going on at the ostium. So number one, we size distally with the IVUS this way. Number two, we clear the ostium of any significant lesion. In fact, it was negatively remodeled, so we felt comfortable going ahead and doing this in this case. And then this was actually the denervation procedure. This is the Paradise system. This is not approved here, but certainly you could do this with the Medtronic system as well into the distal branches. So those are sort of tips and tricks procedurally. So just to conclude in the last couple minutes, what's the target population? Who are we going to be treating this with? Well, first, I think it's important to recognize that especially in resistant hypertension, adherence is an issue. And so even though patients may be on medications, theoretically, they may not be taking them. And so this is a great population of patients to treat. And in the trial, Radiosound HTN, whether you use the Medtronic system or the ReCore system, these are the patients who got significant reductions in blood pressure. This is daytime ambulatory systolic blood pressure drops of over 10 millimeters of mercury. These people will actually have a difference, and because they have severe hypertension, they actually will likely have clinical benefits, although that remains to be shown in randomized trials. Again, a word of caution, if you have very, very stiff arteries where the pathophysiology might not be sympathetically driven, it may not work as well. There are some data showing it can work in isolated systolic hypertension. I'd certainly want to hear Venkata's comments on that. But I personally think that in patients with stiff arteries that are volume responsive, it may be less useful. So who are the patients we're going to select? Number one, it's going to be hypertension refractory to medical therapy or with adherence issues. You want to rule out secondary cause, and I typically would say that CT-based screening is best. It's going to typically be patients with sympathetically mediated hypertension. Hard to sort that out, but clinically you can kind of get a sense of that. And then anatomy that's suitable for denervation. So variable by device in terms of the accessories and whether you can treat them or not, and no stenosis at all. Just a cautionary tale, remember, with statin therapies, we know there are many patients that have atherosclerotic cardiovascular disease who simply are not taking their statins. We have to, even if we're considering denervation, do a better job at lifestyle modification and medications, and innovative care solutions are needed. There are ways you can measure blood pressure at home and have patients engaged in their own care, and if they see their blood pressures are elevated, they're more likely to take their medicines and employ lifestyle modification. Therefore, they might not need denervation, or if they do denervation and they still have elevated blood pressures, that's the importance of taking medicines over time. I also will mention there's a lot of good studies at taking hypertension care into the community. In the United States, this was done in LA County. They did blood pressure cuff and monitoring as well as pharmacologic or pharmacist interventions at barbershops to ensure that patients could truly be informed about their care and got dramatic reductions in blood pressure with medicines alone. So if you're going to employ a denervation clinic, don't just put up a shingle and have a shop saying, I do renal denervation. Make sure you're doing all of these preventative care efforts, and systems, big systems of hospitals are able to do this quite effectively. There's actually a very nice paper in the JAMA Cardiology as well from the Mass General Brigham where they didn't even use physicians. They used people who had just graduated from high school and used them to educate patients to take their medicines more effectively, and they had better control of cholesterol, they had better control of blood pressure, and that's important to do even before you consider renal denervation. So my last slide, I know I've gone a little bit over time. I just want to mention, number one, hypertension is a real public health problem. There are many sources of poor control or even resistance or pseudo-resistance. At present, lifestyle modification and medical therapy remains the mainstay of care. This is not going to work if you just try to denervate every patient. You need to really emphasize lifestyle modification and medical therapy first. If that fails, then at that point, we know that renal denervation has established efficacy over sham in multiple carefully conducted trials. And if safety can be confirmed through the longer follow-up period, look for this technology to be approved, at least in the United States. I know it's approved here already, adding it to our clinical toolbox to treat blood pressure. Thanks so much for your attention.